Good morning, everyone, and welcome to the Health Committee for the Council of the County of Renfrew. It is Wednesday, April 10th, 2024, the appointed hour of 9:30 a.m. I am calling the meeting to order. As we gather this morning, I wish to acknowledge, on behalf of committee and our community, that we meet on traditional territory of the Algonquin Nation. We thank the Algonquin people and express our respect and support for their rich history. We're extremely grateful for their many and continuing displays of friendship. We thank as well all the generations of people who've been careful stewards of these lands for millennia. Ms. Johnson, has the roll been called, please?
Good morning. Yes, roll has been taken and we have quorum.
Thank you. We do have quorum. I would invite any disclosure of pecuniary interest, and if any, the general nature thereof, please. I see none. I would seek to a motion on the minutes of the previous meeting held on March 6th and March 27th, 2024. Councillor Murphy, seconded by Councillor Weir. Any errors or omissions? I see none. All in favor? That is carried. Thank you. I do also, as a bit of housekeeping, committee, you will have received yesterday afternoon an addendum, which is somewhat a misnomer. In fact, I would suggest that it is an amendment. Typically, an amendment would be a next number in addition to where we left off. In fact, late breaking, there is also an agreement similar to McKay Manor, that is item number 5 on the emergency services report, was added to item number 5. So I'm just to be very careful. What I would seek is a motion to amend the agenda. What we are amending is the agenda that was distributed on Friday is being amended to accommodate a new number 5. So I would seek a motion to amend. Councillor Grill, seconded by Councillor Wilmer. Any questions or comments? All in favor? That is carried. The agenda is amended. With that now, I would invite Deputy Chief Grenier, if you would be so kind as to introduce our delegation this morning. Very much looking forward to the information.
I would like to introduce Lindsay Bergen as a coordinator of epidemiology from Public Health. Lindsay brings a lot of knowledge and is going to present us the substance use related arm in Renfrew County District. Thank you, Lindsay.
Thank you so much, Deputy Chief. This is the first that I have actually met Ms. Bergen. I knew her as Ms. Derman, but only in her role as a TV star. This is the first in-person performance, so the floor is yours, Ms. Bergen.
Just making sure this works. Perfect. Okay, so thank you very much for the introduction. My name is Lindsay Bergen, formerly Lindsay Cameron Derman, for those that might know me from that name. I work at the Renfrew County and District Health Unit, and I'm the coordinator of epidemiology. So before getting into this presentation, I did want to just stop to mention the fact that I will be discussing some sensitive material, including things like local emergency department visits and local fatalities. And we wish to acknowledge all families and friends and loved ones of individuals who may have lost their lives to substance use, and of course the individuals themselves. And if required, there are some supports available on our webpage. So in the first few slides, I want to discuss some distributions of harm reduction supplies. And there are a few supplies that I'll be talking about. And these are supplies that individuals can receive from our health unit locations, as well as community health partners, organizations, as well as some participating pharmacies. So the first supply is needles or syringes. So I will go through the graph here because there are a few pieces of information. And so the height of the bar represents the number, the count of needles that were distributed in a given year. And then there's also 2 lines on the graph, the dark green representing the line or the rate for Renfrew County and District, and then the gray for Ontario overall, just so that we can compare our distribution rates to the provincial rate. And so what you can see is that since 2018, the number of needles being distributed is actually decreasing across both Renfrew County and District and in Ontario overall. And this may be due to some changes in the modes of drug use that people are using to consume drugs. And we'll get into a little bit more of that context later on in the presentation. Okay, so two other supply types. There are straight stems as well as bowl pipes. And you can see in both locally and provincially, there has been an increase in distribution of both of these supplies since 2016. And then lastly, there's naloxone or Narcan. And so again, we've seen significant increases in naloxone distribution. In 2022 specifically, more than 4,600 doses of naloxone being distributed. And then this chart only goes until 2022, but preliminary data for 2023 shows that pharmacies themselves distributed more than 7,000 doses. So the height of the bar for 2023 will be quite high. And so this is important context to have just because there's an increasing amount of naloxone being circulated around our communities. And so this likely has an influence on the number of people that actually seek healthcare services in the event of an overdose. And this can include things like calling 911 or visiting an emergency department. So when we get into some of the trends on the next few slides, it's just important to have that context. So this is one of those trends I was discussing, and that's opioid overdose-related emergency department visits. And this is specific to visits to our local hospital institutions. The height of the bar here representing the count of ED visits in each calendar year quarter, starting in 2020 of Q2. And so the last available data point was 2023 Q4. I know we just finished Q1 of this year, so I'll give a bit of preliminary context at the end. But in 2023 Q4, there were 20 confirmed visits for opioid overdoses. And that was comparable, maybe a bit higher than the previous quarter, 2023 Q3. But we were a bit higher than what we were seeing at this point in time in last year. And what's not shown on the slide is that our rates locally are actually pretty similar to what Ontario overall is. As I mentioned, we did just finish 2024 Q1, and it does look like the height of the bar there will be at least 25, if not more. So we are continuing the trend of seeing heightened activity in our local emergency departments. All right, some of these slides are going to be specific to Ontario overall, and I included these slides. They're from the Office of the Chief Coroner for Ontario. They're very helpful to include some provincial trends in the absence of having some similar comparable local evidence. So we can just kind of use that as a proxy to see maybe that is occurring here locally as well. So this trend is opioid toxicity deaths, again, in Ontario overall. It's a 20-year trend graph, so starting in 2003. The height of the bar for 2023 only includes the first 3 quarters, which is part of the reason it is a bit lower compared to the other bars. So what they're looking at is when we look at the trend, we're looking similar to what the rate was in 2021, which was a historic high peak, maybe a bit lower. It's suggesting maybe about a 9% decrease. But what you can see is that the rates are remaining quite a bit higher than what they were in 2019 and earlier. And what's not shown on this graph is just some demographics of the individuals that have passed. So about 3 out of 4 deaths involve males, and about 70% of deaths involve those aged 30 to 59, so middle-aged adults. All right, so flipping back to the local context, here we have opioid toxicity deaths in Renfrew County and District, starting in 2018 up until 2023. So in 2018, 2019, seeing about 5 deaths per year. 2020 to 2022, those bars are higher, anywhere between 2 and 4 times higher. And then in 2023, we had 21 deaths. That only includes information January to October, so unfortunately the height of that bar there will be a little bit higher to end 2023, and so that has been historically our highest year with respect to confirmed opioid toxicity deaths. There is another graph on this slide. It's on the right-hand side, and it just talks about some of the geography of where these fatalities are occurring. It's important to mention that toxicity deaths have occurred pretty much across Renfrew County and District, but just in the spirit of planning maybe some targeted efforts, it does appear that Pembroke's mortality rate is about 4 times higher compared to the remainder of Renfrew County and District. And that's since 2018. So moving forward, these are more just of the provincial trends that I had mentioned, and I'll sprinkle in some of the local context where available. This slide looks at the living arrangements of individuals at the time of their passing. In Ontario overall, majority of individuals do live in a private residence. But in 2020-2021, there was a disproportionate increase among people experiencing homelessness, and that's represented by the widening of the orange bars there in about the center of the graph. Locally here, we do receive some information, not for all of these fatalities, but we did note that there was an increase in deaths among people experiencing homelessness in Renfrew County and District in 2023. So this is a good example of using the provincial context to see what's going on, and shortly thereafter we are seeing a similar trend. The next slide, in a similar vein, discusses material resource marginalization. And so this again is Ontario context, but about half of all opioid toxicity deaths are from individuals that live in areas that experience the highest level of material resource marginalization, or another word for that is deprivation. And so these are individuals living in areas where they have extreme difficulty attaining basic material needs. Moving along, talking about presumed mode of drug use. So it's important from a service and treatment perspective to understand how potentially individuals are consuming drugs. And in Ontario overall, there has been an increase in evidence among people inhaling drugs, and that's represented by the red line that's kind of trending up over time. And so since about 2020, approximately half of opioid toxicity deaths had some sort of evidence of inhalation. And what's interesting is that the number of deaths with evidence of injection only is actually decreasing, and that's represented by the narrowing of the green bars on the graph there. And so tying that back to our needle distribution, this may be one of the reasons why we're seeing less needles being distributed in our communities. Okay, the next, so not only is it important to understand potentially how drugs are being consumed, it's also important to understand what types of drugs are being consumed. In terms of opioids, we still know that fentanyl contributes to the vast majority of our opioid toxicity deaths. But in recent years, there has been quite a bit of evidence of polysubstance use, where there is more than one drug involved in an opioid toxicity death. So there's lots of bars and colors on this graph here, but it's basically showing the proportion of deaths where there was evidence of another type of drug, where green is 2023. And so for stimulants, you can see in 2023 they were involved in about 2 out of every 3 opioid toxicity deaths, with cocaine being in about half and methamphetamines in about a third. Also benzodiazepines, also common in opioid toxicity deaths. And so we do have a limited data with respect to toxicology from the coroner's office on our local opioid toxicity deaths. When we look at things, we do see that trends are similar to the provincial context, and that we're seeing an increase in evidence of polysubstance use, specifically the use of stimulants. in individuals passing from opioids. Okay, so the next two slides are my last two slides, but they are about more broad than just opioids specifically. And so when we receive data from the coroner's office, we know that it often takes time for the coroner's office to confirm which drug or drugs were involved in a fatality. And so instead, in the spirit of trying to get more timely information, they provide us a weekly update on suspect drug poisoning deaths. And there's a criteria that they review, and if a death meets it, then it's included in these counts. That's in the back in the technical appendix. And so this can involve any type of substance or where substances are pending. So in 2018, 2019, as shown on the graph, we were seeing about one suspect drug poisoning per month in Renfrew County and District overall. And then that line has trended upwards, where in 2023, it was about 3 deaths per month with a total of 38 suspect drug poisoning deaths. And so when we look at 2023 as a whole, on average, a person was passing away from a suspect drug poisoning every 10 days in Renfrew County and District. We did just finish Q1 of 2024, and there's still some data pieces coming in, but between January and about mid-March, preliminary data shows that we had 8 suspect drug poisoning deaths so far this year. And so unfortunately, if that kind of rate or trend continues, we'll also be looking at another relatively high year. And then lastly, looking at emergency department visits, not just for opioids overall, but for any type of substance. And these can include things like alcohol, cannabis, cocaine. And so again, just broadening up that discussion and acknowledging what hospitals are seeing when there's individuals presenting. So there has been not only an increase in volume in substance use related visits, as shown in the graph, there's also a combination of things that emergency department visits are seeing. There's evidence of polysubstance use, so individuals consuming more than one thing at one time, and that makes treatment a lot more difficult. And so in 2022, about 10% of substance use related visits specifically involved opioids. Again, many of them including more than one substance, but this just shows that the problem of substance use certainly includes opioids, but the conversation can be much broader. So I will end there. Again, there's technical notes and some definitions in the next few slides. But yeah, I can try to answer any questions, and if there's something I can't answer, I can take it back to my team at the health unit.
Thank you very much in a very condensed time frame, a very comprehensive report. Very pleased to receive this. And I think perhaps setting the stage for questions or comments, your advisory at the outset comes back to me at the end. We're looking at a lot of metadata here, and it is discouraging and troubling, the metadata, but what is more troubling to me is these data points have been living, breathing people, the toxicity deaths in particular, with loved ones, with families, and it is a scourge. I note on page, I think it was slide 8, where it gave a graphical representation. 2021 seemed to have been a high watershed year prior to this year. On that slide, November and December were not included. When on slide 13, by the time you got to that one, I think you had suggested, Ms. Bergen, that it was 38. So it has doubled the worst previous year of 2021, and it's more than 3 times as many as 2022. This is suggesting to me that we are not making inroads, notwithstanding our best efforts, but we are seeing this on the rise. With that, I will certainly open the floor. Any questions or comments? I will begin with Councillor Murphy, please.
Thank you, Chair, and thank you, Lindsay. As I said to you when you came in, this was not bedtime reading. I couldn't agree with the chair more. Just reading it, and then you remember that these are all we're living, breathing people in our community that obviously needed help. And It's very distressing. I think the slide that caught me the most was the one where the gray bars indicated that when these people died, we didn't know whether they were housed, unhoused, living on the, and that again is a distressing stat when you're seeing it grow and grow and grow, where we just didn't know where these people were. And yeah, it's quite startling. I was just going to ask if Diane would be so kind as to pull this from our package and send it separately. This absolutely needs to go to our local tiers. I think everybody in the county of Renfrew that sits on the council should know what is going on through our CDHU. So thank you for putting this together. I do not envy your job. Thank you.
Thank you. Councillor Purcell, please.
Thanks again, Lindsay, for your presentation. 4 times the opioid-related deaths in the city of Pembroke compared to Renfrew County District. Not a surprise. We see a lot of issues, and I think that there's some good things that are happening in regards to attention to the matter. I know that Mayor Gervais hosted a meeting with various different organizations such as the Renfrew County District Health Unit, paramedic services, police services last Friday, and we've been talking about the MESA program and kind of getting a better handle in terms of what we can do collectively to address these types of issues. So I think I think we need to continue to keep our foot on the gas and continue to learn more about some of the concerns and the issues and address these concerns. And it's unfortunate. It's a sad situation, but I think collectively we can really make a difference and improve the situation for those individuals that are struggling with addiction, homelessness, and hopefully prevent some of these deaths. So thank you again.
Thank you. Any further questions or comments? Councillor Nicholson and then Warden Emo.
Thanks, Chair. I'll just echo the other points, Lindsay. Thank you. Pikwaktagon. They've recently declared an emergency related to opioid deaths. Are their numbers included, or have we access to those?
So in the overall numbers, they are included. I received this information from the coroner's office, and so it just includes our catchment area as a whole. I do look to them for them to provide some specific numbers for their trends and things, because sometimes definitions of what constitutes these types of deaths might be a bit different. But yes, in looking at our overall numbers, if there was someone that passed away from opioids and or just substance use in general within Algonquins of Pikwakanagan, they would be included in the overall total.
Thank you. I'll go to Warden Emo and then to Councillor Lafreniere.
Again, thank you very much for the information, and I'm curious, is there, how widespread are your presentations to other service providers? I'm just curious how widespread the information is. Thank you.
So I have presented this information a few times over the last month or so. We have our current community overdose response plan that the health unit chairs and leads, and there's a variety of community partners that sit in on those meetings and get these materials. And then us at the health unit ourselves, we're looking at providing some of these tidbits of information on our webpage, really in the spirit of trying to get this information out there through different channels. So it's something that we're working on for what we can do to increase dissemination of this material. But yeah, I feel, because I've done it a few times now, I think the word is slowly getting out there. I appreciate your channels that you might have as well to be able to further share this information.
Follow-up, Warden?
Great, thank you very much, because I think your information is likely the ground floor from which those of us that are charged with serving the community, or have some of the responsibility for overseeing it. I think this allows us to use this information to form new partnerships and possibly new methods of caring for individuals. So thank you. And is this a quarterly or an annual report, or what are your expectations?
Because there has been so much activity and so much interest, I do like to provide information at least on a quarterly basis. That's what we've been doing with our overdose community response partners. Again, we are working to expand that. Like, we are at the health unit working to develop just a broader community drug strategy, where I know there'll be some other important key players around that table. So I'd say at least quarterly, and again, with what we're hoping to put on our webpage, it would be quarterly updates. And in the event that there is something that we notice, for example, on a weekly, within a certain week, if one of the indicators are kind of sticking out, maybe that there's something notable going on, we work with our community partners just to see if we can get a little bit more information, and then we'll post a media release if there's something that's urgent, and not just in the quarterly update fashion.
Thank you. And final comment. This is a bit of a political comment, so you may want to plug your ears, but so what this demonstrates is the ability of the local community to get information that allows us to focus on meeting the local needs of our community. So it allows us to share information and be nimble, as nimble as we can be when you're talking about a series of organizations across our community, but to be able to respond to our community needs using your information, so using the excellent research abilities of Renfrew County District Health Unit. So thank you.
Thank you, Warden Emo. Councillor Lafreniere, and then I will come back to Councillor Murphy.
Thank you. I want to thank you for that presentation. It's enlightening, and it's encouraging that there's so much information going out now to those who maybe don't know what's going on or don't believe it's that bad. So, I mean, you've got the proof on paper. I want to say that the increased naloxone distribution, looking at as bad as that is, because so much naloxone needs to be circulated, it's enlightening to know that so many of our community members are recognizing it, because it's not just those with addiction picking up these kits, it's family members who are concerned about a loved one. It's maybe just the general public, because they do come into contact with these individuals that look like they may need assistance. So it's encouraging to know that individuals are picking up these kits. I do have a question to the presenter. There was one slide where you talked about some of the individuals that lost their battle. We're living in areas with lack of access to materials. I think that was the word you used. Would that be services? Could you sort of just clarify what was lacking in the communities they were living in?
Yeah, that's a great question. So this is looking at, there's different aspects of marginalization. This specific one is material resources. This is something that's developed kind of on a provincial level. So what they do is they actually look at various things that come through census data, and they use these different types of indicators, and it's really the most closely linked with poverty and individuals' incomes. So it's looking at all of the dissemination areas, which are small little units of geographies all across Ontario, and basically looking at the highest kind of income neighborhoods, I would say, versus the lowest income neighborhoods. So it's really just a measure of income and a couple other things that get put into that. So it's individuals that are living in those geographies or neighborhoods that are more likely to pass away. And so just to keep that in mind, if someone is living in a low income dissemination area, which would be those that would maybe have hard time accessing these different types of things, it doesn't necessarily mean that they are low income themselves. It's just the geography that they're living in. Similarly, you could have somebody that has a low income living in a relatively high area where there is maybe more income. It's just based on just those different pockets of geography. So again, it's just mostly closely linked to poverty.
Okay, well, thank you for that. We all know that the larger centers are the ones that have the services when it relates to addiction services, detox, treatment, et cetera, And I mean, the news that we're listening to now about our own community is disheartening, to say the least. But I know that Belleville advocated strongly because of the crisis they were faced with, and the provincial government, I believe, has answered the call. I mean, we'll wait and see when it comes to fruition, but I certainly know that everyone that I've been talking to at the municipal level and the county level supports, increased services of that nature. So I think we should continue to advocate to the provincial and federal governments. Anyway, I want to thank you for the report because, these individuals that have lost their battle, they're like a stone being thrown into a puddle. The ripple effect of their deaths, the magnitude is unknown. It affects family members, coworkers, individuals. So you're right. You can take that number of fatalities and probably multiply it times 50 or more, how many people were affected. So thank you very much for your report, and thank you.
Thank you, Councillor Frenier. Councillor Murphy, and then back to Councillor Nicholson.
Thank you, Chair. My question is actually for the warden. Would it be a good idea perhaps to bring Lindsay back, maybe not at the end of April, but at a point in time where she's got an update right to County Council so that all 17 hear this? I mean, I know now Pembroke has had an opportunity, but I think that maybe this is such an epidemic that perhaps all of County Council should hear it. Thoughts?
If I may, Chair?
I will come to you just in a moment. The other element, this is, of course, being posted to YouTube, this very presentation, so certainly that can be extended to all of council, and I hope when I last checked in there were 10 people actually watching live, which is refreshing. So there is that avenue as well. Warden?
Thank you. And I think with the permission of Lindsay, what I'd like to suggest to you is that we have a model that we've been slowly pursuing now where we identify the issue or the concern, and then we supply to County Council and the community what measures we have in place to assist. And so I think if we follow that model logically, that may be something that'll happen in May or June, or maybe even in August. Simply when, with fresh numbers, we'll have a little more detail of the MESA program as it rolls out. We have some housing information that we're working on right now. So I think rather than piecemeal it all out, it would be nice if we had a package so that we can reassure the community. I think we're going to have a motion come forward from the City of Pembroke, if I remember correctly, asking about support for services with regards to addiction. And they were kind enough to change their motion to rather than insist upon it being located in Renfrew County, that it serve Renfrew County, because I think one of the things that they talked about at their council meeting was the need for to ensure that there was enough volume to convince the government to establish the service. And for sake of argument, if it was located in Arnprior or maybe Fitzroy Harbour or Pakenham, then it filled the need of our community, but then also the need of possibly Ottawa if there's an overflow, and then possibly Lanark County right at that apex. So I think if we can wait, that as the chair has noted, this information is out there, and Lindsay's done a great job of getting out to other service providers. We'll also see, and I can't remember the exact, there's a steering committee that Dr. Morgenstern is in the process of establishing, so I'd like to see that roll out as well, rather than sound an alarm and give the impression that the community is scrambling around and has no plan. There is a series of things that are coming together. So with your permission, I would think that would make more sense. Thank you.
My apologies. I meant later on. I think this bears repeating.
Thank you, and I think in that event too, the proper channel to go through would be to go through the health unit, and I'm sure that would be probably the preferred process that Ms. Bergen would have as well. And I think if I'm understanding it, is certainly the messaging, and I'm appreciative of the warden. It's important to note that we are looking at some stark numbers, but it's also important to note that the MESA program has just stood up. So we are talking about 2023. Unfortunately, early data from 2024 seems to be mirroring that, though we are just finding our feet with the MESA program. It is going to be on the agenda today. This is being discussed, but I think that, as with almost everything that is public health, it is the public that must engage. This is a whole of society response that is going to be required in this instance. So it's important to have absolutely the data that the scourge, the crisis of substance use and addiction, mental health, homelessness, it is an incredible problem within our community, but we have now stood up a program. We are also, I think perhaps this summer is when we anticipate hearing the results of the SUAP grant, that is the Substance Use and Addictions Program, but we didn't wait for that. We went ahead and grabbed the bull by the horns with the MESA program. We recognized the challenges right across the community, most acutely being felt in the city of Pembroke currently, though I must note in the Eganville paper just of this morning, the issue is rearing its head with a couple of opioid deaths, or what is being suggested as opioid deaths in that municipality, and certainly 2 deaths in a municipality of that size is an incredible number as well. So the messaging is going to be critical towards standing up the response to the challenge that is before us, but I'm much appreciative of the warden's comment that it's important that that be balanced with not just recognizing that we have an issue and a challenge and a crisis, but that in fact there are measures being put in place even as we're speaking. With that, to you, Councillor Nicholson.
Thanks, Chair. And I'm just going to echo some of the concerns or the issues or comments that both you made and the warden made. When I reflect on the presentation that Lindsay provided this morning, the thing that jumps out to me is so what? So the information is great. So what can we do? And I acknowledge the MESA proposal that County Council has put forward. Incredible, you know, to break down those barriers and do something that we haven't traditionally done. But is it enough? And I can't answer that question. And I know I'm sometimes wearing my county councillor hat, sometimes my municipal hat, sometimes my health unit hat, sometimes just a concerned citizen hat. But I don't know if we've done everything we should have. And I have to recognize, you've said it, the warden has said it, the medical officer of health has initiated the community drug strategy that's coming out. Seems to be the avenue by which we can assess all these different the silos together to come up with a coordinated community response. I just want to recognize how important that is, and I believe there's going to be municipal representation, so our community government will have a voice in that, in addition to the public, in addition to the medical experts. So on my first point, community drug strategy, I see it as the thing that I'm leaning on to advise me in those different areas. The second point that I want to raise, I'm reflecting directly upon as a county councillor, and in my mind, is this an emergency? If it isn't an emergency, what indications would exist that it becomes an emergency? Are there levers that if it is declared as an emergency, the county would then have the ability to do something more? I don't know. I'm not suggesting, but I just want reassurance that we as a county council within our silo, within our lane, are considering that, weighing our options, and we can make that recommendation to the warden or leadership when appropriate.
Thank you. Councillor Weir, please. We'll take Councillor Weir, and if there's one more, and we're going to have to call it there.
Yes. Thank you, through you, Chair. Thank you very much for putting this reality out so the public can understand it. Just one thing in regard to your presentation, the slide deck that I have on slide 13 shows it's a suspected drug poisoning deaths in RCD. On my slide deck, the graph is there, but the text that you had in your slide deck was not in our slide deck. So I'm just asking that we update slide 13 prior to sending it out to all the townships so that it adequately reflects what you presented to us today. Thank you.
Absolutely. I can connect with those that I've been involved with to do this presentation and maybe just provide an alternative format to make sure it all appears. Thank you.
Yeah, and I think perhaps, if I may, Councillor Weir, was it the finite number, the 38 number was not, certainly Ms. Bergen presented that in her remarks, but it's not on the slide.
On slide 13, Ms. Bergen's had text on the left-hand side of the screen and a graph on the right. Ours has the graph, but none of the text.
All right, thank you for the clarity. Final to you, Councillor Purcell.
Thank you, Chair. I just wanted to respond to Councillor Nicholson in regards to emergency status or and I know that we had some discussions last Friday with the with the warden. We had OPP, we had the grind, Renfrew County Paramedic Services, as well as the health unit, Ontario Addiction Treatments Centers, and some other participants in a special meeting to look at what efforts we're going to put forward. And we had agreed at that meeting that we are considered an enhanced state of operations, and that we're going to continue to monitor. And the reason why we say that is there's a lot of things that are coming forward in regards to the MISA program. There's additional foot patrols that are happening on the streets. We have kind of all hands on deck kind of approach in terms of working with various different partners, as well as the Pembroke Regional Hospital, to kind of continue putting a focus on prevention and seeing how we can prevent these things from happening. So we continue to monitor that, and we're meeting on a regular basis. So just so you're aware. So those things are continuing and ongoing. Thank you.
Thank you for providing that information, Councillor Purcell. One final question, and this jumped out at me actually in the presentation, Ms. Bergen. Is on slide 7, that is page 16 for those of you on your PDF. Kind of astonished that 75% of deaths are male. Is that in alignment with substance use, or are the deaths actually overrepresented amongst males?
I'd have to look into that for sure. I think substance use for various substances is more common among males. I don't know to the degree of how much more they may be disproportionately impacted when it comes to severe outcomes like fatalities. But this data is for Ontario overall. But when we look at our local data, in terms of demographics, it's actually quite similar as well. The majority of local deaths that we're seeing are males, as well as middle-aged adults. That being said, though, these things can happen to females as well as younger individuals and older individuals.
Thank you very much. And just the final comment that I want to make, and most of the discussion and the questions and the comments here have been with regards to opioid deaths. And certainly that is the most extreme and acute, urgent driving force. But of course, the usage itself of opioids continues to be a crisis in our communities. And I think that it is two-pronged, is to meet the challenge of the preventable deaths and to reduce that, which is ultimately the goal of public health at all times. As Ms. Bergen had indicated, and I'm sure everyone has heard it now, your postal code is more disposed towards indicating what your health is going to be than your genetic code it has come to be. In any event, it is important to keep in mind that the opioid or drug use issue is much larger than the deaths. As I indicated, it is most acute in those that have perished, but it is much larger than that. And I will, in deference to the warden, there will be one more.
Thank you. Just with regards to that slide, and it talks about 3 and 4 deaths are among males, and 70% of the deaths are among those aged 30 to 59. The average age of the people attending the warming center is 44. And last week when I was at a breakfast with Minister of Finance, Bethlyn Falvey, he suggested that he was hearing that the age group 18 to 50 was indicating a high degree of a sense of being unmoored, unappreciated, no hope for the future. And so I think I'd mentioned it at one point in the last little while. I'm not sure how we've lost that cohort from 18 to 50. All of a sudden, they're unmoored, not feeling attached to a community, not having any hopes or aspirations. And so the coincidence of numbers. So I'm kind of wondering how and then I'm not asking Lindsay to answer this. I'm kind of wondering how we've lost that cohort, and those numbers again sort of point to that theory. Thank you.
Thank you very much, and I think that once again underscores your own point, Warden, that I think we need to be very careful in the dissemination of information. Our communications at all time must recognize the measures that we are taking, that it is simply not underscoring the scourge and the crisis that confronts us, but here is what we are doing. I think that it is two-pronged, that we must meet their emotional, intellectual, physical needs, but we also must be able to offer some sense of assistance and hope to these folks. Once again, Ms. Bergen, thank you very much for the presentation. I think it was incredibly informative. Obviously, it sparked a very engaged conversation here, and I think that conversation will and needs to continue. And certainly at the pleasure of the health unit, at the probably smallest interval, would be more than welcome to have you back to keep us informed on developments on what is happening in this very challenging environment. Thank you very much. With that, you will find committee on page 30, the beginning of the Emergency Services Report. I would invite you to go there, and I would invite Chief Nolan to take us through the report, please.
Yeah, thank you, Mr. Chair. Through you to members of committee, and a big thank you to Lindsay for the presentation that we provided. I think it underscores a lot of the reasons that MESA is what it is and where it's at in its own development. So certainly appreciate that. And as per number 1 in today's report, there's been a considerable amount of work occurring within the MESA program. And on March 20th, there was an opportunity with our partners at the Upper Ottawa Valley Health Team, or Ottawa Valley Health Team, to be able to bring together a number of partners from across the sector. So there were 20 community partner organizations that came together regarding a new collaborative approach to compassionate care, which of course is the tagline for MESA. And with that, our intention is to set an agenda to be able to convene a partners meeting, much like the incredibly successful event that Jason and Andrea Craig hosted last week related to housing. So we'd like to follow in their footsteps and pull together the social and health lenses as it pertains to MESA to complement the work from the Housing Summit last week. And in doing so, we've been able to also engage a number of different program areas in relation to the services that we provide. And of course, MESA is not to replace anything, it's to enhance everything in the way that we engage vulnerable populations and serve them within our mandates, but also be able to collaborate in a way that I hope everyone that comes to the table is able to do more, not only because of their individual contribution, but because of the collective, the exponent, if you will, of the approach that we're taking to MESA and its population. And again, I'd just like to remind committee that MESA is about mental health writ large. It's not only if you have mental health,
and you have addictions, and you're homeless. It's about mental health, it's about addictions, and it's about homelessness. And I think that that's a key component, Mr. Chair, in terms of where we're going, because when you look at it through that sort of that tri-concern lens, there are a significant number of agencies, individuals that are working in this space, and the feedback that we've received to date is that there's a welcoming of setting a table, bringing these various organizations together and having this conversation. And just in case there's any concern about overlap in this space, we have had conversations with Dr. Morgenstern regarding the community drug strategy and how all of that fits together too. We have met with the Ontario Health team to say what committees already exist and how do we ensure that we're not overlapping. So that's why the partnership with the Ontario Health team in the formation of the March 20th meeting was invaluable. So thank you to Ms. Watt and her team for supporting Deputy Chief Grenier in that experience. But then as we move forward, we need to better understand these various lenses. I think the name of a community drug strategy kind of makes you think it's about a drug strategy. But as we know through the social determinants lens and harm reduction and prevention, to be able to affect a drug strategy, there is a mental health component, there is a housing component, there are a number of different elements such as income security that's provided by Ms. Patrick's team. So I think when we pull it together, it will start to emerge and make more sense in terms of how these various swim lanes are going to collaborate and not duplicate. But even if there is a little bit of overlapping, that's probably not a bad thing, because I'd rather that than the gaps that we have in the system today. And from there, I think there's ample opportunity for Mr. Kelly, the warden, and all of us to be able to educate the provincial and federal governments about the gaps that exist, the overlap to a degree that exists, and the lack of policy and funding support that the county has for many years been seeking from the province and the federal government to support the housing initiatives that we're putting on, and to be able to support Ms. Patrick's work, whether it be Ontario Works or looking at the housing conditions that we have. So it is a multifactorial approach that is complex, but we are happy to be able to share, Mr. Chair, the dashboard that is capturing a snapshot in time since March 1st of the early work of the MESA team, and just to give you an idea of some of the activities that are going on within this space, because we think that it's critically important that as we not only learn as we go, but we're also creating an evaluation framework and we're gathering data as we go as well. And I just want to share this. Mr. Kelly asked me to share it with the group, and this work is really a reflection of the collaboration between Development and Property, Community Services, and the Paramedic Service. So as we continue to grow, we'll be layering in new performance indicators and new metrics related to the system at large. So, what does this represent in terms of the team? This is a live dashboard that our teams are contributing to, minute by minute, hour by hour, every day. So it's live, and we're looking at it predominantly through the paramedic lens right now. So we're gathering information about interactions with individuals, situations related to persons and personal harm. We're looking at this is the MESA encounter with an individual, and how many of those are happening because of a 911 response, how many of those are we leaning into in a harm reduction and prevention way, and happy to show that it's almost 100% increase, or it is 100% increase of encounters and engagements that are outside of a 911 call. And in simple terms, for me, this means we're not waiting until it's too late to get involved. We're actually engaging early and earlier, and I think that this number will continue to separate the experience that we're having in the conversations built on a relationship of trust. To date, again, this is just MESA with one community paramedic, because we're in the process of onboarding our social service partners in this role. It does include some of the responses as it relates to the foot patrol that we've been doing collaboratively with the OPP. But we've, the MESA team alone, this isn't how many responses overall, but the MESA team has had 29 911 responses to people suffering from mental health,
homelessness or addiction since March 1st. So it is already very active, as you can see. How many of these related to people who are already clients of ours within the MESA program? So as we meet people and we gather their medical history, we include that within our electronic medical record. So essentially we have like your doctor's office file or the VTAC file. We already have a file on board, so we can understand a bit of your history and a bit of the experience that you've had. When we look at where situations have been occurring, we know that right now this is a very Pembroke-focused team as we're learning and growing in this space. Big partnerships with the Grind, the OPP, the City of Pembroke, and so on. So I expect that these numbers are going to become, far more diffuse across the county as we continue to grow, because we're only about, I would say solidly, we're only about a week into this. We've been adding staff as they come available. We're adding more sophistication to our engagement. So this will continue to grow to be county-wide. We've also been funded for 2 teams. This only represents 1 person of one of the teams, not 2 teams of 2 people county-wide 7 days a week. But that being said, when we're looking at how encounters occurred, we're looking at what's virtual, what's by video, what's by messaging, what's in person, what's the primary reason for the encounter. And so you can see that it's really the gambit of the things that we had envisioned, which is what are the clinical interventions, mental health, behavioral wellness checks, 911 support and follow-up, clinical care coordination, situational awareness, health education, public health, public safety concerns, community outreach. TOC is transfer of care from an ambulance crew or other. So this is very relevant to us because we want to be able to build out the knowledge and skills associated with each of these reasons for the encounter, and that's where, as we bring on the expertise of Renfrew Victoria, Pembroke Regional, and McKay Manor, we'll be able to provide greater support for the staff that are involved in this, which will then translate into greater support for the individuals receiving the service. What are the clinical outcomes? So assessment by paramedics, wound care, medication administration, point of care, POC testing, as well as consultation with the physician nurse practitioner, which is today often VTAC in this program, and then ambulance diversion. So you often hear me say, why do we do what we do? This program, along with many of our other programs, such as community paramedicine, VTAC, and so on, our goals, selfishly, have been to reduce 911 calls, to reduce transportations to hospital, to reduce hospitalization, and to reduce death. And so we have some early numbers. Again, this is really a week and a half's heavy lifting, which for something that represents less than 45 days worth of activity. But we can see that we've already leaned into this population. We've already diverted 26 emergency department visits and 25 ambulance transportations. Why does that matter? Because if this program is designed to protect the 911 resources for all of the other emergencies that happen in our community, it's already showing benefit to increase paramedic availability, 911 paramedic availability for people outside of this program. Your heart attacks, your strokes, your car crashes, your everything else. So that's a good story in terms of, is it making an impact? It's already making an impact in terms of our 911 availability and lessening the workload on those ambulance paramedics, 911 paramedics who need to be available for everything else that we're doing. So it's protective. Often it's not seen because you don't know what you're not involved in. And even a single ambulance transport diverted can reduce the engagement for an individual patient by hours as it relates to transportation, documentation, offload delay in the hospitals, and so on. So some critical information here that we've been able to glean. In terms of care coordination, again, if we're going to respect the other organizations such as Home and Community Care and these other agencies, we're going to track how many of these people we're encouraging or bringing to them so that they can provide the services. There's some latent capacity within the system. Some are overwhelmed, some have some capacity. So how do we exercise that in a meaningful way and be able to measure it? Yeah, I can try. Yeah.
Yeah, is that better? Yeah, thank you. When we look at public safety outcomes, one of the things that we've been doing a lot of is consultation with service organizations, consultation with emergency services. So we're working very closely with police, particularly, and also with public health to be able to share information, to be able to support this population. We're also gathering narratives. So this table is linked to other documentation that's available so that if there's a story to be told or something to be learned, so we're taking a qualitative evaluation, qualitative research method, we're gathering those narrative and those stories so that we can potentially publish that outcome, but also be able to share the information within the team as we continue to move forward. So we have 70 responses in relation to gathering that qualitative data. So, Mr. Chair, that's a bit of a snapshot. Maybe hand it back to you in case there's questions while I have this open. If you wish, I'm happy to entertain those now as opposed to having to reopen the Zoom.
All right, thank you very much. And as you'd indicated, I think there is a pragmatism in taking questions on this right now. Councillor Murphy.
Thank you, Mr. Chair. The back row crew couldn't see most of that. Is there any chance that we could get a copy of it? Like, could you cut and paste? The glare from the windows, Neil moved it just the last slide, so we were missing some pertinent information. Thank you.
I think that can probably be distributed. Any further questions or comments on any aspect of the presentation? Warden Emo, please.
Yes, thank you. So I hate having to do this, but number 11, slide number 11, where it talks about the time on call, ED, emergency department diversions, and ambulance transportation diversions. Do we have financial costs for that? Because I think we have to, part of when we present to ministry at some point for permanent funding, if this is where we want to go, I think, one of the successes we've had is to talk about, and I think the proper term is upstream savings, or maybe it's downstream savings this time, but anyway, our investment, our investment would be upstream to save downstream. But is there a series of financial numbers? Because I think this is a great model of collecting information, but I think those 2 or 3 pieces will allow us to go back to the ministry in a year or so and say, look, these, you can fund this because it makes more sense financially for you.
Chief? Yeah, thank you, Mr. Chair, and thank you, Mr. Warden, for that question. And when I go back to, even quoting you on that, and we talk about, hospitalization at $32,500 per month, and you are quoted in the appendices as well on that. The attribution has been provided. Yes, we have the data. Thank you for it. We also use CIHI data in terms of emergency department visits. And our goal is to, again, gather up a relevant number of experiences and then be able to pull all of that back together for you to be able to say, here are the offsetting costs, here are the offsetting savings potentially. But I think at a more global level, what we're doing here is being able to not only quantify the effort, but also to be able to define the new model. Because many of the things that we're reporting on have novel components, new components in the way that we're looking at the population and looking at our role. And in doing that, showing, I'd like to say once again, that it's not just about moving the eggs around in the basket to find new ways of doing things. It's about changing the way we look at the services we're providing and leaning in a way that has arguably the greatest impact on the individual, but an equal measure of opportunity for the system provincially to be able to change the way it interacts with vulnerable populations such as the one we're serving here.
Thank you. And if I might just not a follow-up question so much as a statement. I really think what we're doing at this point is acting like we expected the Ontario Health teams to act, which was to coordinate services and to, act as a clearinghouse of information. So I'll leave it at that.
Thank you. Just for committee and perhaps those that may be watching the live stream, when Chief Nolan references CIHI, that is the Canadian Institute of Health Information, which was the basis for some of the information contained therein, and it is always advisable to liberally sprinkle quotes of the elected throughout any documentation. Anything further?
I'd like to speak, sorry.
Oh, sorry, I'm missing you once again, Councillor Lafreniere. My apologies.
Apologies not needed. I forgot to raise my hand. Just a couple of questions for Mr. Nolan, for Chief Nolan. The calls and the calls to service that are indicated on your spreadsheet, would some of these have been answered by the regular paramedics if MESA did not exist? Or are these new types of interactions or calls for service? That's my first question. Chief?
Yeah, thank you, Mr. Chair. When a call comes in for service from 911, the current provincial interpretation is that 2 paramedics and an ambulance must be sent. We have boots on the ground through MESA in the core community in the same way that we provide community paramedic response units. And one of the, I think, important ways to think about the role of the MESA paramedic, who really are community paramedic response unit paramedics, with a different population of interest. And the goal here is that the vast majority of our time is in harm reduction and prevention, and whether that's providing wound care, providing psychosocial assistance, connecting people with services. In the same way, if you think of community paramedics, identifying populations of older adults with complex chronic disease who may or may not be on the wait list for long-term care. Really, we have community paramedics and the addition of some social professionals to be able to support that team, identifying people with mental health, addictions, and homelessness related. So really, it's about changing the population of interest because we know that it has had a significant rise in its complexity and enormity over the past few years, as Lindsay showed in terms of the changes within that population. But there's also a different specialty that's required to be able to support that population. So if it goes through 911, an ambulance with 2 paramedics is sent. If the community paramedic, in this case MESA, is there and is able to assess the situation and cancel that ambulance, then that frees up those paramedics to be available for the next 911 call. And in the simplest of terms here in Pembroke, if there's only 1 ambulance in Pembroke and they're tiered to go to a call and the MESA paramedic is able to free them up because ultimately the patient has chosen to not go to hospital, but that choosing to not go to hospital typically occurs because you have options available to you, whether they be paramedic options or other options, then that's a good thing, because if they don't and the paramedics get engaged directly with that patient, the 911 paramedics, then we're probably taking an ambulance from Petawawa and moving them into Pembroke to provide coverage within the area, or in some cases from Deep River or Eganville or Renfrew. So there are a number of dominoes that we're trying to halt from having to fall because of one single response within the community. And I think that that's important broader context in terms of availability. You know, I've used that sort of drain analogy in the past where we can have all the ambulances start their day in Eganville that we want, but they're not going to spend their day in Eganville or cover off that entire part of the county because they're going to spend their time in Pembroke doing call after call after call after call. Our goal is to stabilize the core, right, to essentially plug the drain so that Eganville can stay in Eganville and Petawawa can stay in Petawawa, and that Pembroke can manage the issues of the day in Pembroke. The MESA team, the current one, has the ability, and we've shown it through our statistics, to be able to keep those 911 paramedics available, whether it be for that patient and be able to manage that patient, because let's say Narcan doesn't work. Let's say the patient says, I insist on going to the hospital, which is not something we often hear within this population. And or they're available for that next call because the MESA paramedic has provided an immediate stopgap measure to be able to assess the situation and not obligate those 911 paramedics to then take them to the hospital, be stuck in offload delay, potentially, or be tied up potentially for hours on end while Eganville is now in the Pembroke area waiting for that Pembroke crew to be released. So it has a big impact at source.
Okay, thank you. I guess the second query I have is if you're doing outreach to an individual who does want help, does seriously want to get better, we know that there are services in our community that are not available, such as a detox. And we know that detox is a primary indicator. If they want to go to detox, you know they're serious about getting better. If someone says, I want to clean up, where do you bring them? Do you put them in contact with a mental health worker? Or because that's a gap in our community, and I'm not saying it needs to be on your shoulders, but it's definitely a gap. Because if you find someone that wants help, but we can't help them, I mean, they will go to the hospital. And the sad part of all this is I've heard of individuals that have gone to the hospital because they want to clean up. So they end up making up a story at the hospital. Now, this might sound far-fetched to some, but it certainly is the truth. And they tell them that they're going to do themselves harm. That's the only way that they'll be taken into the mental health unit. That's sad. And they will only be kept for a few days and then released. So I'm just wondering, are there talks around the table? I know that we have a great group of organizations on how we can actually help these individuals get where they need to go to detox before treatment. Any discussions around the table about that issue?
Chief? Yeah, thank you, Mr. Chair, and to you, Councillor. So what I can say is we have some exceptional partners within the program and within the county that will be able to provide direct connection. That's why partnering, as in item number 5 today, with McKay Manor, Renfrew Victoria Hospital, and last meeting's memorandum of understanding with the community mental health programs will provide these individuals the best chance for having throughput to the services that are currently available within the county. That being said, there are some missing links in the chain in Renfrew County, and that's not to say that there aren't detox programs available in the province, but I think the warden spoke to it earlier and may want to speak to it again, in that we are attempting to control all the things that are within our existing policy and funding envelopes and use them to their maximum advantage, but there are some services that are not directly provided here in the county. Detox is likely one of those services that could have a greater representation, or we have greater access to services, and I'd leave that to the chair and the warden to speak to because it was referred to earlier. We are trying to do at the MESA boots on the ground level of understand the need, connect people to existing services, and I think what that's going to do is shine a light on where those gaps are and what those unintended consequences are of people bouncing in and out of the system. There's also a significant amount of effort going on with Mr. Kelly, Mr. Davis, and Ms. Patrick around housing options for people, and I think that's also part of that conversation in terms of the safety and security that comes with not being in a precariously housed situation, as the MESA document outlines. Mr. Chair.
Thank you.
Well, thank you. Thank you. I just want to thank you for that comment. And it's nice to know that you're making sure that we're trying to find all the holes in the bucket so that the water doesn't leak out, because that's what these gaps will cause, right? You'll try to carry them through, but it's nice to know that you've got people in place that know the issues. Thank you.
Thank you very much, Councillor Frenier. With that, then, I think we will carry on with the agenda report, please, Chief Nolan.
Thank you, Mr. Chair. Item number 2. From the Community Paramedic Response Unit team, just a couple of quick updates, including the new CareDove version 2 referral program. And this is a electronic record system that's used across hospitals, home and community care partners, primary care, and so on. So paramedic services across Ontario have entered into agreements with CareDove to be able to support referrals predominantly, and then be able to access services more seamlessly. So thank you to Matthew and his team for pulling that together. As well, we've instituted a new skin tear pilot program with referral pathways, and a lot of that's around wound care, and then also new assessment tools. And when we look at where the effort is going within the program, certainly the collaboration between the Community Paramedic Response Unit program, CPRU, and the VTAC program, there's a considerable amount of collaboration going on to be able to support patients, and I just want to thank everyone for that work. And it's good timing in terms of shoring up some of the activities within the community programs, because on the 911 side of the house, the medical priority dispatch system is coming to fruition. And for those of you that have been around these chambers long enough, we've been asking for 20 years to modernize the provincial dispatch system, and this is one component of that modernization. And I'm happy to say that the City of Ottawa's paramedic service is going live today with their implementation of MPDS, and we go live 1 month from yesterday. So very happy to say that there's been a considerable amount of work with our team by having Commander Paroli in the communication center to better understand the intricacies of the great work that the dispatchers do on behalf of the Ministry of Health, but ultimately serving our community, and also to acknowledge them and in their role, because they are often quite silent in their role. While they're the first person you talk to when you call 911, they're often not thanked or congratulated to the degree that they should. And this enormous change management and software system is being implemented. It's going to change a couple of things for us, a lot of things for us, but probably the most visible for you is that we're no longer going to have code 1, 2, 3, 4. You get to learn a new language, but luckily it's paint by colors this time, not paint by numbers. So it's going to be a purple, red, orange, system. So we'll get into that greater as I report on our performance and on our data. But there are other things that we'll not be tracking, such as standbys and other things that are inherent to the software. We have a relatively short list of things that we would like the province to consider because of the way that we deliver our services here that might not be done elsewhere. So we're going to continue to engage. I can only say exceptionally positive things about the management and the staff at the Renfrew Central Ambulance Communications Center. They've been a pleasure to work with, and they've had some provincial support that's been quite understanding and sympathetic to our innovative ways, and we'll find ways of integrating that as we go along. So thanks to them and all of the senior team and the frontline paramedics who were involved in our planning for this event. Item number 4, Mr. Chair, is the Treasurer's report, and happy to see that the Treasurer is in the room, so he's here to support any of that conversation, so thank you, Daniel. And then, Mr. Chair, we're starting to move towards number 5, so I will turn it over to you.
Thank you. We will review the information items then, committee, going back to page 30. Anything further on the community programs, Mesa? Item 2, the CPRU. Item number 3, the medical priority dispatch system. Warden Emo, please.
Thank you. And just to Chief Nolan, thank you very much for spearheading this. I know that I dragged you into at least 3 calls on this, and I certainly appreciate your input and your standing within the paramedic community, which allowed us to move this forward. Quick question, any update on the Kingston situation? Are they also moving forward with us? Because I know that, and you'll be more accurate than myself, they were not scheduled to be brought in around the same time as us, which was going to cause us problems across the Warden's Caucus catchment area. So I haven't heard an update from the minister in a while on this.
If I'm not mistaken, I think there were 3 tranches of the rollout. Is that correct?
That's correct, and happy to expound on that if I could. So the The rollout across the province, just for context, is that it began in Mississauga over a year ago, and then moved to Thunder Bay, Kenora, and then moved to Eastern Ontario. So Ottawa and Renfrew are thought to be bundled, and that's why we're launching 30 days apart. And next on the list was Georgian. What I've been assured is that Georgian and Kingston will be going about 30 days apart. So I know that they've begun the planning, and there was quite a bit of concern that it was going to be Georgian and then what. The ministry has committed to its Georgian and then Kingston as, again, a pairing, much like Kenora and Thunder Bay were, and Renfrew and Ottawa have been. So I don't have specific timelines, but I do know the ministry has committed to timelines for that implementation, and they have begun the planning process with Kingston and Georgian communication centers.
Good
Follow-up?
Yeah, and no, just a thank you for that. And again, that's good news. And kudos to the ministry for recognizing the validity of our concerns.
Thank you. Anything further on item 3? I see none. I do want to certainly echo the chief's comments with respect to the dispatchers. It is committee, I'm fairly certain, doesn't have this authority, and council will be, unfortunately, after the fact. But Admaston Brumley at our council meeting just last week did in fact proclaim April 14th to 20th to be the National Public Safety Telecommunications Week. And this is recognizing the essential and integral component that communicators certainly in Ontario, in the CAC centers, the Central Ambulance Communication Centers, as the chief has noted, when you are having a bad day, that is the first person that you are likely to be talking to, and they have been integral. And in fact, their kind of place in the structure here is actually going to be increased, which is the ideal, is to even more acutely have the right service in the right place at the right time. So certainly hats off to the telecommunicators. Perhaps next year we could have this in our March agenda, that the county could consider that as well. But that is next week, April 14th to the 20th. So I think it is worth an extra shout out to them. Moving on then, the Treasurer's Report. Any questions or comments on the Treasurer's Report? I had a couple. I'm sure that's a shock to everyone. First off, inordinately pleased. I cannot recall the last time I saw a parenthetical number on the top right of this report, so it is very encouraging. The other thing that I'm actually, and I think that it may be somewhat undervalued, is that on the paramedic employee benefits line, substantially under budget to the tune of $500,000. And I think that may actually be somewhat suppressed, given that the line directly above that is showing a paramedic salaries that is over budget. Typically, one would expect benefits to move in lockstep with salaries. In this instance, we are seeing a substantial reduction. I don't know the particulars of that. I don't know, Chief, if you will, or if that is something we would pass on to Mr. Burke, but I do wonder at a high level if in fact that is indicating that we are beginning to make inroads into the presumptive PTSD. As council committee, rather, will recall a few years ago, perhaps just in 2022, I think we increased substantially the payroll burden factor to cover this off, and I'm just wondering, Mr. Burke or Chief, if you can provide some insight into that.
Yeah, thank you, Mr. Chair, and maybe Daniel, if I miss anything, if you could clean up for me, that'd be great. There is an obvious relationship between those two lines, and we have had, I think, remembering that the period of this total report for last year also reflected the tail end of the pandemic. in terms of some of the policy-related and financial-related issues to last year. So we did continue to see an increased sick time rate beyond what we had originally budgeted, which drove some of the paramedic salary-related lines. We also onboarded a number of different programs mid-year through the year, such as hospital support paramedic staffing, where there are corresponding revenue amounts that are allocated towards some of those overages. So while that line does have pressures related to WSIB and sick time, there are also some offsetting revenues within the budget, which give you the parentheses in the top right-hand corner. And that's part of the leveling effect within that budget. We also have had a significant amount of overtime, end-of-shift overtime, because it's been extraordinarily busy for the reasons that I think everyone in committee is well aware. When we think about one of the pressures that was not referenced within the previous part of the report, and I wasn't sure if the warden was going to bring it up, but the MPDS program is intended to assist us in reducing our calls into the City of Ottawa, which was also a significant pressure in terms of everything from meals to end-of-shift overtime and so on. So we're hopeful that the reallocation of priorities within that group will also result in a reduction in the pressures related to intermunicipal billing, which could and should have been part of the offset in relation to this line. And I'm sure I'll just hand it to Mr. Burke through you, Mr. Chair, in case there's anything he'd like to add to that.
Mr. Burke, jump in, please.
Thank you, Chief Nolan, and good morning, committee. Just to focus specifically on that WSIB comment, so we are at the end of our 3-year WSIB evaluation cycle. So for the 2024 year, we will have to redo that actuarial study to determine where we're at. I wouldn't want to give anyone the impression that we're coming down. I would say that we've plateaued in the level of cost we're seeing. But because our burden factor is based on a percentage of gross earnings, and our gross earnings are significantly more than we had budgeted for, that burden factor had a reduction in it. So we did make a year-end adjustment to substantially reduce the WSIB costs, not because we're paying less in absolute, but because we're paying less as a percentage of gross wages. That's what we're seeing. So the costs remain, I would say, relatively stable year over year as to what we're paying WSIB, but as a percentage, because we're increasing our salaries and our salary expenses, we're seeing that percentage drop a little bit.
Okay, thank you. I still, from my perspective, I think that if we are seeing the substantial increase, year-over-year increases that we've been experiencing for quite a number of years, if in fact we have bent that curve downwards, that is a substantial gain just the same. Thank you very much to both Mr. Burke and Chief. Those are the only questions I had. Anything further? I see none. On to the bylaws, please, Chief Nolan.
Thank you. Yeah, yes, extremely, and on a regular basis. So just further to Chief Nolan's comments, the City of Ottawa, in our discussions with them, we're very hopeful that the new model MPDS would also alleviate some of their staffing tightness, and then would allow our service plus Lanark County plus Prescott Russell to stay within our boundaries more often. So it, I think we're all very hopeful that this is a model that will allow a greater use of our own resources within our community. And again, just to note, the paramedic service update indicated that the Eastern Ontario Wardens Caucus catchment area loses 17 shifts per day to hospital loading times. So that's a significant amount of money in up to 2022. So it'll be interesting to see what 2023 numbers bring and in the future. So it is, MP or NDPS is going to be closely scrutinized to see if it is an answer for a lot of our problems. Thank you.
Thank you very much. Hope and reconciliation. I think that's the solution. Moving on to bylaws, please, Chief Nolan.
Thank you, Mr. Chair. Item number 5, recommendation that the Health Committee recommend the County Council adopt a bylaw authorizing the warden and clerk to sign letters of agreement with McKay Manor as represented by Community Withdrawal Management Services of Renfrew County. And there's a second
Could I just, and I should remind committee, you should now be looking at the addendum, which is the amended number 5. Sorry, back to you, Chief.
No, thank you, Chair. And the second recommendation that the Health Committee recommend that County Council adopt a bylaw authorizing the warden and CAO sign letters of agreement with Renfrew Victoria Hospital as represented by Addictions Treatment Services for the provision of addiction and withdrawal services related to the MESA program.
Could I have a mover, please? Councillor Murphy, seconded by Councillor Purcell. Background, please.
Thank you, Mr. Chair. This recommendation proposes and solidifies a partnership between the County of Renfrew McKay Manor as represented by Community Withdrawal Services and Renfrew Victoria Hospital for Addictions Treatment Services. And the goal is that MESA clients will now have access to the full continuum of services within the county. And to deviate from the narrative, Mr. Chair, that at the last meeting we signed an agreement with Community Mental Health and Pembroke Regional Hospital. So this represents some of the major players in the county who have stepped forward to offer their assistance in working with the community paramedics and the MESA program to have boots on the ground so that psychotherapy, social services, and access to the various programs that are represented by these 3 partners, 2 of them today, 1 of them last meeting, will be on the ground and available to our community in a way that we've not been able to achieve previously. This will also work in collaboration with the OPP and its teams, which are offering similar services to different populations as well. So back to you, Mr. Chair.
Thank you very much, Chief, and certainly this is in, I think, keeping with one of Councillor Frenier's comments, and while these aren't precisely plugging all of the holes in that bucket, they are substantially reducing the holes in that bucket in now providing the architecture through which these services can be provided. Any questions, comments? Councillor Purcell, please.
Thank you, Chair. Just a couple, I guess, comments and a question. So can you explain that these are just the outpatient withdrawal management services? Because there's an inpatient withdrawal management services that are available through McKay Manor and strictly for men. And again, a requirement for that particular intake is detox of 72 hours. So again, we're getting back into those gaps in terms of the services, just trying to set people up for success. I think there's 12 level 1 beds and 4 level 2 beds located in McKay Manor, but again, it's just geared towards men. So, I mean, maybe that has something to do with the motion that we brought forward at City Council in regards to, working with the county to come up with, an opportunity to look at, enhanced, treatment services and supports. But could we maybe just include that as, like, would they have access to the inpatient services as well?
Chief Nolan.
Yeah, thank you, Mr. Chair. And yes, the goal here is really to be able to lean into the population where they're at, whether that's clinically or socially, housing, income, and so on, and be able to get as direct a line of sight to those individuals to the in-house programs, both at PRH, the RVH teams work, and at McKay Manor. So within the services of McKay Manor, by having them built into our team, it then be able to afford people greater access to those services because we can prepare people more adequately for direct entry to those services wherever possible. That's not to displace anybody else. It's about how do we kind of do the pre-departure check, if you will, to be able to take you from a precarious situation and into those services. So within this funding and potential transitional housing opportunities, it's not only what services can be provided at McKay Manor or at PRH or at the various institutions, it's how do we create extramural programs or have them supporting people with wherever they're at. We know there are capacity issues across the system, so by being able to add additional resources as part of the MESA team, we can then hopefully support greater throughput greater access to care within their individual mandates, but also having them working in the MESA configuration. And there are a number of other very practical, technical reasons that this is beneficial. There are collective agreements that say these workers at this organization only work 10-hour days. We only work 12-hour days. Some can only do 8-hour days. Some are only Monday to Friday. So by tapping into all three organizations, our goal is to be able to better advantage the clients ultimately, but also advantage these organizations by being a part of the MESA team and contributing however they can. And that's why these are on a fee-for-service basis, so that we can purchase the services necessary to support the goals that Council has given us from a MESA operational configuration perspective.
Thank you. Follow-up.
Thank you so much. I appreciate that. Again, I just want to reiterate, if there's no opportunity for individuals to get to attend detox, to get that 72 hours in terms of to meet the entry requirements, I mean, there's a big gap, right? And I think, we had those discussions last Friday, and we're going to engage with, Pembroke Regional Hospital, and I think the CAO took that action on, the CEO of Pembroke, took that action on to look at opportunities in terms of, detox opportunities within, hospital, the local areas, because, I mean, to send somebody outside of county to detox for 72 hours so that they can access a residential treatment program just doesn't make sense to me, right? So those are the big gaps, and I think we need to kind of, understand that is a big, big issue in our communities right now. So thank you.
Thank you. I think I certainly recognize the challenge. I think as we are standing this up to, we should be careful not to make good or excellent the enemy of good. So obviously that is a substantive gap, the detoxification. But ultimately, as we are moving towards a much more streamlined process, I think that these are very valuable agreements just the same. Councillor Renfrew, I'll go to you next, please.
Yeah, thank you. Not to belabor the conversation around detox, but it is a complicated issue. To direct it to Chief Nolan, has it been explored to possibly engage the conversation with the Ottawa Withdrawal Management? They have a 7-day detox. So I don't know that you would want to engage them, but they do have a larger program. I think they have more beds. I know individuals that have gone there. And it is complicated as well. You have to call them every day to say, is there a bed? Is there a bed? Is there a bed? But has there been that option discussed?
Chief. Thank you, Mr. Chair. I would say no, not from my office, Councillor Frenier. But what I can say is that we're working on these concentric circles right now in terms of who are our immediate partners, how do we build out the capacity within the immediate partners. And in fact, I would be very confident to say that these three organizations that we're partnering with would have articulation and relationships with those next level of concentric circle. And that's why by bringing in their expertise and recognizing their expertise, I would see them bridging into their respective lanes so that they can find opportunities for throughput. I think the frustrations that I've heard in these council chambers are the exact same frustrations I've heard from these organizations, and the limitations of whether it be their funding, their population mandate, their policy frameworks that they're handed down. And Ms. Patrick, has been doing a great job of educating all of us in terms of the quilt work that really is social services. And when one government has a great idea and they put money in a policy at a single agency for men between this age and this age, or women between this age and this age, and youth, and so on, it's an incredibly complex ecosystem of services that these organizations welcome the opportunity to collaborate at a higher level because they've told me, they've been working in their silos based upon the mandates they've been given. And that doesn't necessarily advantage the population we're serving. So the clear answer to you is no. I've not had those conversations, and there's a pretty good chance that I will not have those conversations, but we'll rely upon the experts that exist to be able to find those collaborative opportunities. That being said, Mr. Kelly has been urging us to identify other organizations and best practices in Ontario that we can learn from, so I expect that there will be some articulation with programs such as the Salvation Army, the Shepherds of Good Hope. The Cochrane District has done very good work in Timmins as well, supporting this population, and has been able to share back some of their experiences as well, such as the Suboxone program and their addictions treatment services. So a bit of a longer answer maybe than you wanted. It could have just been a no, but I think it's important that you understand that we're trying to be respectful and leverage because we cannot do this all ourselves.
Thank you.
I think that it was probably fine with Councillor Frenier. It's longer than the chair wanted. I think perhaps, Warden, you may have had something on this particular point.
Very quickly, if you look at area number 5 in the scheduling of staff with the community withdrawal, and it talks about regular deployment and optimal scheduling. And then you look at area number 5 for the Renfrew Victoria Hospital, and it talks specifically, I think, it says that RVH will ensure a staff is scheduled 5 days per week to provide addiction treatment services and referrals for residential treatment programs throughout the county of Renfrew. And I think that speaks to Councillor Lafreniere's question, is that they already have the relationship with treatment programs, and they recognize when the beds are open and across. So they're within that realm of getting pretty quick answers, and that's who I used to use, was to use them as my arms and legs, because why would I make 10 calls when I could make one call and they could get back to me? So I think one of the primary things that MESA is going to provide is probably a case management perspective with an overall view to serving each individual client, whereas now sometimes clients get lost in every agency doing a little bit, and there's not a coordination or a true understanding of what that is. So I think, and the CW community withdrawal model, it's a valuable component because some people cannot go to detox. Their personal history, if they were abused in a group home or have anxiety and issues about being around other people, they can't go. And sometimes it takes a community withdrawal at home to break that cycle of dependency. So I think the partnerships that we're establishing are valuable because they have a proven track record of working within their lanes, and I think MESA will bring that together, but also provide the case management function or the focus of the wholeness of the treatment plan for people. So I think we'll be very pleasantly surprised with the results at the end of December. Thank you.
Thank you for that. And when I hear case management, it even strikes me that even system navigation is probably a substantial barrier to a lot of folks. Anything further on item number 5? Seeing none, all in favor? That is carried. I'd now seek a motion to accept the emergency services report as a whole, please. Sorry? Oh, that's okay. So I guess I only got the motion on the first one then?
You did, Chair,
okay.
On the McKay. You just need the RVH piece.
Okay, so I will need then a resolution on the second recommendation. Can you read that once again, Chief Nolan, please?
Thank you, Mr. Chair. The second recommendation that the Health Committee recommend the County Council adopt a bylaw authorizing the warden and clerk to sign letters of agreement with Renfrew Victoria Hospital as representative of the addiction treatment services for the provision of addiction and withdrawal services related to the MESA program.
Thank you. I'd seek a mover, please. Councillor Yon, seconded by Councillor Lafreniere. All in favor? That is carried. Now I would seek a motion to accept the emergency services report as a whole, please. Councillor Weir, seconded by Councillor Wilmer. Further and final opportunity for any question or comment on anything in the emergency services report. Seeing none, all in favor? That is carried. Thank you. Is everyone content to continue? I'm getting an indication, I'm getting a high five. I'm assuming that means 5 minutes. It will be a solid 5 minutes. Actually, you have 6 minutes. That clock on the striking of 11:20, we shall be coming to order once again. Brief recess. Hurry up, everybody. Thank you, everyone. We are back. I'm just doing a quick count for quorum. 1, 2, 3, 4, 5. We're fine. Oh, and we have Councillor Lafreniere. We are fine. Mr. Blackmore, if you'd be so kind as to take us through the long-term care report.
Thank you, Chair Donahue. On page 41, the report begins. Item number 1 references the 2024 Ontario budget, and more specifically, those budget items of significance to long-term care. We can expect each home to receive specific allocation notices in the very near future. Items include a 6.6% increase in level of care funding. This is fairly atypical. Typically, we run about 2%, for which that's what we budgeted for actually for 2024. So that's going to mean a significant additional revenues in that envelope. I'm going to just roughly estimate at this point until Mr. Burke can verify later when we get our letters, but it's in hundreds of thousands of dollars for each home. B is the continuation of medication safety technology program. Both county homes, like many homes across the province, have used this funding to invest in what are called automated dispensing cabinets. Unfortunately, these are items that are currently back ordered, so we hope to have those in place at the home soon, and perhaps we'll be looking at purchasing more with the additional funds. C is additional funding tranches for allied and nurse and PSW supplement aimed at achieving 4 hours of care per resident per day. And this also represents the significant funding over that which we had budgeted for, neighboring in roughly $287,000 for the manor and $75,000 for the lodge. D is a significant unanticipated minor capital increase in funding, and I'll speak to that further in item number 6. We did actually receive a notification for that amount. E is for resident health and well-being funding, and it expands upon the list of eligible allied health professionals for which that fund can be applied to. That particular funding ends, it's limited till March 2025. Item number 2 notes the public health inspection conducted March 26th by Inspector Shannon Thorpe for the Renfrew County and District Health Unit, with a 1 item corrected at time of observation, resulting in a 100% inspection compliance. The report in its entirety is attached as Appendix Long-Term Care 1. Item number 3 is the 2023 unaudited financial statements for Bonnechere Manor and Miramichi Lodge. Starting with the Manor report on page 50, and recognize there's a whole lot of figures in there and a whole lot of different funding envelopes and expenses, but in a nutshell, Bonnechere Manor realized a $3.2 million surplus. And as you'll see, some of the major expenditures include that of nursing services that were 3.5 million under budget in wages, but this was offset by $3.4 million in agency staffing. Most other expenses were relatively close to the budgeted amount once COVID funding was factored out. And there was revenue of $3.5 million that was over budget, of which $2 million relates to the prior years of adjustments for the RPN and PSW staffing supplement, for which we had recently received a notice from the ministry that we were able to utilize that funding for more than just increasing base staffing, but more generally for recruitment and retention efforts, including existing staff. Miramichi Lodge had a $2.1 million surplus. All expenses were close to the budget amount as far as expenses go, but the revenue was $2.1 million over. Again, that goes back to a $1.3 million adjustment made from the prior year tied to that RPN and PSW supplemental fund. And resolutions.
Actually, we'll pause there, Mr. Blackmore, and I'd invite committee, if you return to page 41, we will review the information items. Item number 1 is the Ontario budget, and there were several different components attached to this. Any questions, comments? I had just discussed at the break with Mr. Blackmore. There are several line items here, and I'm just kind of curious if any of these had been anticipated for our long-term care budget, or if in fact anything that we are eligible for, whether it be either or both homes, will this be supplemental to anticipated revenues that were discussed at the adoption of the budget?
Thank you, Chair. Through the committee, and Mr. Burke, you can help me out with this perhaps. This is a preliminary announcement, so we haven't received the individual allocation notices just yet. But for the most part, these are in addition to that which we had budgeted for. Particular relevance is that level of care funding at 2%. Again, a 6.6% increase is fairly, well, very much atypical. Typically, we would get a 2 or a 3. And in addition to that, the capital fund that kind of came out of left field as well, a welcome addition of roughly $450,000 per home.
Okay, thank you. So if I'm understanding correctly, I don't know if within each of these separate line items, if necessarily either the County Renfrew long-term care homes may be eligible, but whatever we are eligible will be supra to revenue streams anticipated in our budget, correct? Correct. Mr. Burke. The other thing I wanted to, so on that level of care specifically, and we'll come back to the unaudited financial report shortly, but I'm just curious, for Bonnechere Manor on the revenue line page, and that committee is on page 55 of today's report. And you'll note on grants and subsidies about halfway down there is provincial revenue operating global LOC subsidy. So in 2023 we had budgeted just under 497,000, received 492,000. Is that the sum to which that increase is applied? I.e., would it be $492,000 increasing at 6.6%?
So through you, Chair, at this point, we're not certain. So when the province talks about operating funding or the old operating funding, there's about 15 components of that, of which one is that flat level of care funding that we usually get. Most of the time when they reference a per bed amount, they mean the per bed per diems, which is nurse operating, either the nursing, the food, the other accommodation envelopes. So very likely that's where we're going to see it, not in the level of care, which is not based on, not expressed as a per bed amount anyways, usually. So still too soon to say exactly where that increase will be divvied up amongst the operating revenue.
Well, I do know that several of these specific envelopes do make reference to a per bed, and that is multiplied by 180 for the manor and 166 for the lodge. But this level of care, per Mr. Blackmore, I think our estimation was we provided an increase of 2% for our budgeting purposes, but in fact the increase will be more than 3 times that. And that page 55 that I'm making reference to, there are 12 different envelopes in there, the very top line of which is the global LOC subsidy. It certainly seems that is what they're talking about with that global level of care increase.
Through you, Chair, to committee, there is a separate line item for global. It's a lesser amount than the level of care in its entirety. That makes sense.
I'm certainly satisfied that any of the line items here will be supplemental funding that was not anticipated at budget. So it is good news. It is how ecstatic shall we have noisemakers, or shall we jump through the roof, I suppose is the approach. In any event, thank you. So that was just briefly returned. We will come back once again to the unaudited financial statements at item 3. Moving on then to item 2, the Renfrew County District Health Unit Inspection Report. Any questions or comments? I see none. And finally, item 3, the unaudited financial statements. Councillor Nicholson, please.
Thanks, Chair. I wasn't sure if this was a 1 or a 2, but with respect to the new funding that's provided, I appreciate, or that the province has provided, I'm appreciating that some of that is allocated towards staffing, which is the #1 area that we can't spend money in. And I'm just wondering, are we going to be able to have, or do we have a plan to try to take advantage of that funding, like additional foreign worker program, or there are other initiatives that are in the queue now that there could be additional funding in these areas?
Just before I go to Mr. Blackmore, and you can elaborate, but certainly within the unaudited treasurer's unaudited financial statements, I did want to raise, as Mr. Blackmore had made reference, and as we have discussed at a previous meeting, so eligibility for that enhanced funding, where we had until I think January of this year been under the impression that we were ineligible for that. In fact, we were eligible, and that has consequences that reach all the way back to 2021. So I'm not sure even on the staffing level if it is fairly broadly applied in providing discretion as to where those funds could be allocated.
Through you, Chair, to Councillor Nicholson. So there are envelopes that speak specifically to what staff member need to be recruited or retained, and that the RPN, RN, PSW supplemental, those are the only types of individuals you can hire. An increase to the level of care funding allows us a little more flexibility with regard to maybe perhaps other types of people we could hire. Certainly PSWs continues to be our number one priority in terms of providing that support to the point where we don't necessarily have to rely on an agency in particular at the manor. So yes, the international program is still underway. We've got another 16 coming. And part of the expense we're currently running into right now with having to engage staffing agency is the increased wage that goes with that. And that continues, as well as accommodation and mileage, those types of things. So I think we'll still be spending the money. But I think with this latest announcement, we've got a little more flexibility with regard to other things we could look at in terms of allied health, perhaps more management support as well.
Thank you. Anything further? So we'll come to item 3 then, on the unaudited financial statements. Any questions, comments? I just have a comment, and I'm wondering if perhaps Mr. Burke can shed some, well, probably a tag team, Mr. Blackmore as well. So we did find out, I think in January, maybe, I'm not sure if it was Health Committee or at Council, that in fact the eligibility for that, the enhanced funding dating all the way back to a small component in 21, but a pretty substantial value in 22 and 23, and in 23 even through the last of the quarterly reports that Council saw, which was in fact the September 30th. At that time, we had not made provision to be utilizing those funds. So my question is, and this would be reflected in a couple of places. One would be the overall surplus. First off, it would be the surplus within the long-term care homes, but also the contribution of the long-term care homes in the consolidated statement, final surplus amounts, but also in the various reserve accounts. And these will be showing up at the end of the month in the larger, the full unaudited financial statements that committee and council will see. Ultimately, we are seeing substantial increase in the unallocated reserve, which is ultimately the holding reserve for each of Bonnechere Manor and Miramichi Lodge. So ultimately, that is all preamble, and I think likely to Mr. Burke. So in the funds that we were made eligible for, that we're going to have some retroactive. We were advised, council was advised, I believe in January, that in all likelihood we would have to have a restatement of the 2022 financial statements. But ultimately, is everything that has been captured in our subsequent eligibility, has that all been included in the reserve balances, or will there still be some change to them based on a restatement of 2022's year-end report?
Through you, Chair, these financial statements contain all prior year adjustments as shown as current year items. So know that the package that you will have for tomorrow's F&A with a reserve balance sheet would include any prior year adjustments. The only where those prior year adjustments will appear will be on your audited public sector accounting standard compliance statements. But for our purposes, because we recognize the change in the current year, we have recognized all the revenue in the current year, even though it relates to a 2021-22 funding stream.
So just for clarity, so all of the eligibility that was determined subsequent to multiple years, it is now all recorded in our 2023 year end. Okay, Mr. Burke has nodded, thank you. So ultimately, while there was a lot of variation within the various budgets, and it is, I think, weighted more towards the Manor than the Lodge, but I think between the two homes, there's about $6 million surplus, and I think largely that is driven by that subsequent eligibility that was determined through a great deal of effort by Mr. Kelly and yourself, Mr. Burke. Is that accurate to suggest that eligibility is driving a lot of those surplus?
Through you, Chair. So yes, that would be correct. So of the, we'll say, using easy numbers, Bonnechere Manor has a $3 million, we'll say, surplus. $2 million would relate to prior year adjustments, and Miramichi Lodge, again,
2.1.
Yeah, 2.1, 1.3 would be a prior year adjustment. The other component, though, is that so we determined that the eligibility was increased, so we applied prior year funds, but that increased eligibility also affects our current year operations as well. So on that provincial funding section of your financial statements, you'll see that there's the 4 hour of care, 2 lines for 4 hour of care, and that envisions we would be eligible to keep all of the funding that was announced. So again, that's driving a current year surplus as well.
Okay, thank you. And so we will first begin to see the current year. I'm not sure, when do you anticipate the Q1 Treasurer's report for 2024?
Through you, Chair, if I could optimistically say May, at the May committee meetings.
All right, thank you. I love an optimist. Anything further on the unaudited financial statements? Last thing, and Mr. Blackmore did make note of it, you will see substantial savings in our salary lines on nursing, but if you look at the bottom of that nursing section, you will see it's just about all eaten up by purchase service. So it is simply a shell game as to how we are procuring those services, and unfortunately we continue to have a lot of agency purchase service in long-term care. I know it is weighted much more heavily to the Manor, but I think that the Lodge is not immune from that as well. Anyway, if there's nothing further, then we will carry on into resolutions, please, Mr. Blackmore.
Thank you, Chair. Through to committee. Item number 4 gives an overview of the, shall I just read the recommendation?
Please, yeah, and then I'll get the mover and seconder, and we'll go to background.
A recommendation that the Health Committee approve the County of Renfrew Long-Term Care Homes 2024 operational plan.
Mover, please. Councillor Weir, seconded by Councillor Murphy. Background, please.
A background attaches long-term care appendix LTC 3. Is the County of Renfrew Long-Term Care Homes 2024 operational plan that will conclude the current strategic map for the homes. In November 2017, Health Committee and County Council approved the 7-year strategic map that has guided the annual operational plan. The operational plan is created based on Accreditation Canada recommendations and comments, Provincial Quality Improvement Plan, Ministry of Long-Term Care Compliance reports, Butterfly Approach Project, the residents / substitute decision makers satisfaction survey responses, and the most recent resident substitute decision maker satisfaction survey results for each of the Bonnechere Manor and Miramichi Lodge are attached as appendix long-term care 4.
Thank you, and very literate in Roman numerals. Any questions or comments? All in favor? That is carried. Moving on, please, to item 5, Mr. Blackmore.
Item number 5, business case for Bonnechere Manor. Get rid of that. A recommendation that the Health Committee recommend to County Council that the vacant full-time unit clerk position at Bonnechere Manor be designated a staffing clerk position effective May 1, 2024, and further that the Finance and Administration Committee be so advised.
Thank you. Once again, I'm seeking a mover. Councillor Frenier, seconded by Councillor Grills. Background, please.
Background through you to committee. Attached as Appendix Long-Term Care 5 is the business case justifying the request to change the full-time unionized position currently vacant from unit clerk to staffing clerk at Bonnechere Manor to meet operational needs.
Thank you. Any questions or comments? Once again, I see none. All in favor? That is carried. Bylaws, please.
Bylaws, through to committee chair. Number 6, a one-time increase to long-term care home funding. Recommendation that the Health Committee recommends County Council adopt a bylaw authorizing the warden and clerk to sign the 2023-24 one-time increase to long-term care home funding agreement to assist in relieving financial pressures and addressing key priorities related to Ontario Fire Code requirements, addressing deferred maintenance, and proceeding with redevelopment projects in the amount of $2,443 per bed with Ontario Health, and further that the Finance and Administration Committee be so advised.
Thank you. Once again, I'd seek a mover, please. Councillor Yon, seconded by Ward Nemo. Background, please, Mr. Blackmore.
Background, Ontario Health through Ontario Health East advised the corporation of the County of Renfrew, Bonnechere Manor, and Miramichi Lodge will receive one-time funding in the amount of $2,543 per bed in the fiscal year 2023-24 to assist in relieving financial pressures and addressing key priorities related to Ontario Fire Code requirements, addressing deferred maintenance, and proceeding with redevelopment projects. The agreement is attached as long-term LTC 5-6.
Thank you. Any questions or comments on this item? I think that there was a revamping of the funding envelopes. This used to be what is now called minor capital, and I believe this is the minor capital that was addressed in item number 1. I think it was perhaps 1C that established that it was approximately 2,500, which is what this is. And ultimately, at the Manor, it's 457,000. At the Lodge, it's 422. Total just under 880,000 on that single item within number 1 as well. I think that 800,000 is probably a relative approximation of what the rest of those programs may make as well. These are substantial increases to the funding in long-term care. Any further questions or comments? I see none. All in favor? That is carried. Moving on to item 7, and I believe that wraps it up then, Mr. Blackmore.
Thank you, Chair. Through to committee, request for proposal of domestic hot water boiler replacement, Bonnechere Manor. Recommendation that the Health Committee recommend that County Council adopt a bylaw toward request for proposal BM 2024-02 domestic hot water boiler replacement project for 4 new boilers at Bonnechere Manor to Safco Electrical Heating and Plumbing from Pembroke, Ontario, at the quoted price of $166,000 inclusive of HST, and is approved in the Bonnechere Manor 2024 capital budget, and further that Finance and Administration Committee be so advised.
Thank you. Once again, a mover, please. Councillor Purcell, seconded by Councillor Murphy. Background, Mr. Blackmore.
Thank you, Chair. Through to committee as background, Council approved $250,000 in the 2024 Bonnechere Manor capital budget for the replacement of 4 domestic hot water boilers at Bonnechere Manor. The request for proposal was advertised with submissions accepted until 2 p.m. March 14, 2024. Tenders received as followed. 1, Safco Electrical Heating and Plumbing, Pembroke, $166,000. 2, Francis HVAC Services Limited, Nepean, Ontario, $167,920.52. Safco Electrical Heating and Plumbing provided the lowest bid that met all of the requirements within the RFP. Staff is recommending that committee and council support the award of the Bonnechere Manor RFP 2024-02 domestic hot water boiler replacement project as per GA01 Procurement of Goods and Services Policy, Section 20.7, to Safco Electrical Heating and Plumbing from Pembroke with a bid of $166,000 inclusive of HST. which is within the approved 2024 capital budget. The agreement is attached as Appendix LTC 7.
Thank you very much, Mr. Blackmore. Any questions or comments? I note that it was an incredibly tight. I think there's just slightly over a 1% difference between the two bids on this one. One question that I had for, I think this is probably best directed to Mr. Kelly. In the second last line, this $166,000 is inclusive of HST. I note that when Public Works or Operations are reporting on the various tenders of roadworks infrastructure, it's always exclusive of HST. I'm wondering if we could work out a kind of a standard reporting structure. I think that, correct me if I'm wrong, or Mr. Burke weigh in, is every procurement that the county engages in, is it subject to the net HST, which is essentially the 1.76% rather than the 13? Do you know that?
It is, to you, Chair, it is subject just to the 1.8%, not the full 13.
Okay, and just for, because with my particular OCD, it is doing the calculations all of the time, because Public Works does not include any HST. When we see those boxes that council will be committee and council will be familiar with, one must always add the 1.76, which on a $3 million job is not insubstantial. So perhaps we could move all of our departments towards an aligned reporting.
Thanks, Chair. It'd be nice if we could move ourselves to an aligned procurement process, but we're trying to get there at some point with one person. The issues with various departments and divisions doing their own procurement is some put an RFP saying, please specify including HSE, some do not. So again, we will work on standardization, but there are different divisions doing their own thing. So we will try to coordinate a better approach there.
Yeah, and that was what precipitated the first question. If every purchase that we are making, there will be a 13% remittance made on any invoicing that the county receives, but the net is always going to be 1.76%. So regardless of the nature of what the tender reveals, simple mathematics can provide a standardized reporting to council, I think. Anything further? Seeing not, all in favor? That is carried. Thank you. And now I would seek a resolution to adopt the long-term care report as a whole, please. Councillor Purcell, seconded by Councillor Wilmer. A final opportunity for any question on the report. I see none. All in favor? That is carried. Bear with me as I return to the agenda. We do have the Board of Health minutes for each of February 27th, March 14th, and March 18th, the latter two being special meetings of the Board of Health. I would seek a resolution to receive these 3 minutes, please. Councillor Murphy, seconded by Councillor Grills. Any questions or comments on any of the minutes before us? I do note that I think there's still a couple of, and I brought this, I think perhaps to Warden Emo's attention, though I cannot be certain. There were a couple of special meetings in December and January that I don't think we've ever received the minutes on. One would have been the meeting wherein the estimated sums required was determined in December, and the other was a special meeting in January that was the inaugural meeting wherein Councillor Nicholson was in fact elected to the position of Vice Chair of the Board of Health. So I think we are still absent those special minutes.
Yes, I did pursue that and will again.
Okay, thank you. So we do have a resolution before us. Any further question? All in favor? That is carried. Thank you. Is there any new business? I see none. There was, and Ms. Johnson did remind me, there were closed minutes distributed from our last closed meeting. However, there is no closed meeting today, so they will not be entertained today. So do keep them available for the next closed meeting of the Health Committee. I believe we still continue to not require a closed meeting, correct, Mr. Kelly?
That remains correct.
Thank you. So the date of our next meeting shall be Wednesday, May 15th, 2024. I'd seek a motion to adjourn, please. Councillor Wilmer, seconded by Councillor Nicholson. All in favor. We are adjourned.